A very good afternoon, esteemed colleagues and friends, and a very happy new year to everybody. My name is Yu Chong. I'm a family physician and I'm practicing in Toa Payoh Polyclinic. First and foremost, it is my privilege to have been invited to participate in this CPG work group on bipolar disorders and to be subsequently invited to share with you today on the topic of suicide prevention. I know it has been a long day for everyone. I would like to start off the presentation with a video clip presentation.
Kid, every time I'm pulling out, he's right there. Man, someone needs to talk to his parents, if they're ever at home. What is up with the traffic today? And always, every day, this intersection's always crowded. I hate pulling out of here. I need some of these dumb roads. Oh, there's... Okay, so I'm not even here. Right. Great lady. The princess of parking. Oh, sure. Take the spot. Way to be considerate. Oh, are you kidding me? Unbelievable. Oh.
Thank you, ma'am. Have a great day.
It's about time. Let's see, what do I want?
Yeah, could I add a cookie to that order?
Yeah, no problem.
Yeah, no problem, only guy in the world. I'm sure you need your cookie. The world, your oyster, and he's serving your cookie.
Thanks, sir.
Thank you so much.
What can I get for you?
Yeah, I'll have a tall decaf macchiato.
Yeah, sure, no problem. $3.85. And it might take a few minutes here. We've got quite a line, obviously, and thanks for your patience.
Great. Yeah, great. Great for me. Winning again. Unbelievable. What? What is... What is that? What in the world? What am I supposed to do? How can I do anything about that? Can I even help with that? I don't...
Your coffee, sir.
Oh. I can't take this anymore. I gotta get out of here.
Hey, watch it.
Sorry, so sorry.
Hey, buddy, come here.
Does anybody know where to get that pair of glasses? I wish it's that easy for us to get into the history of our patients. But on a more serious note, I found this video very interesting and relevant for a couple of reasons. First of all, it reflects on the kind of stressors of daily life that a lot of our patients and even ourselves go through. I'm sure you will agree that some point in our lives, or even happening to us every day, the scenarios that you're seeing in this short video clip. And it also shows how the power of perception and how it can influence and cloud our perception and the way we react to situations and stress in our lives. We are all very privileged to be clinicians, privileged to have the patient's trust, and to have access to their intimate personal and medical history. And we are also in a very good position to help them because of the in-depth knowledge of their social circumstances. But that's provided we are actually able to listen and pick up on their cues and their calls for help. So why is suicide important in bipolar disorder? More than a quarter of patients with bipolar disorder attempt suicide somewhere along the course of their disease. And an estimated 10 to 19% actually complete their suicide. And that's a rate that is as high as 15 times that of the general population. While suicide can occur in different phases in bipolar disorder, 80% of suicide attempts and completed suicides occur during the depression phase. So what are the risk factors associated with completed suicide in bipolar disorder? These include a history of attempted suicide, a comorbid anxiety disorder, hopelessness, and the male gender. What about risk factors associated with attempted suicide? There are two groups. One group of factors are those that are more unique to bipolar disorders, and these include the early onset of bipolar disorder, the mixed state, the rapid cycling type of bipolar disorder, depression, and increasing severity of depressive and manic episodes. The second group, which is more generic, consists of the history of attempted suicide, comorbid anxiety or eating disorder, family history of suicide, personal history of abuse, alcohol and/or drug abuse, and being single. In suicide prevention, we talk about the early recognition and diagnosis of both bipolar disorder and also depression. As studies have shown that early recognition and diagnosis, coupled with early appropriate intervention, may improve the long-term outcomes in patients with bipolar disorder. I will next talk a little bit about depression, given that majority of patients with bipolar disorders attempt suicide or complete their suicide when they are in this phase. There's a few interesting points to note. There is variability in clinical presentation in depression, especially in the adolescents and elderly age group. This is, especially in the elderly age group, patients may not present with the classical symptoms of depression, like low mood, poor concentration, sleep disturbances, but instead some of them may present with somatic complaints or vague physical symptoms. Especially in Singapore, with our aging population and our increase in chronic disease burden, we have to adopt a very high index of suspicion and systematically inquire about symptoms of depression in our patients. Family physicians are actually in a good position to actually help our patients with bipolar disorder and depression, because we are frequently the first point of contact for patients when they need help. We also offer personalized and continuity of care, and we are able to have a good grasp of the longitudinal history of the patient's medical as well as social problems. We also have the advantage of having knowledge and good access to a patient's family history, as well as a social background and the support systems that our patients have. With all these factors, family physicians will be able to assist our patients effectively. What are some of the helpful physician characteristics and behavior? Having empathy, having good eye contact, good listening skills, and the next point is a little bit more difficult to do, especially if you're in the polyclinic, not exhibiting signs of being in a hurry when you have 8 to 10 minutes to finish seeing off the patients. Next, I come to assessment of suicide risk. The assessment of suicide risk cannot be overemphasized and should be done in all patients with bipolar disorders. A point to note is that the risk of suicide is not only during the acute phase, but as the illness improves, the patients may actually gain enough energy to actually carry out the act on the thoughts and plans of suicide or of self-harm. So it is very important for all of us to ask for suicide thoughts and plans in our suicide risk assessment, such as the presence of specific planning, the means available to carry out the plans, and the rehearsal of the plans. We can group the factors suggesting increased suicide risk in different ways. One way, of course, you can group it as what is shown here, demographically, or by symptoms, by history, some of which I've gone through earlier, or by suicidal thoughts. Perhaps an easier approach, like what in SAT cages, here's another mnemonic, SAT persons, the S being the sex, A being the age, depression, previous suicide attempts, ethanol abuse, the loss of rational thinking, the lack of social support, organized plan to commit suicide, no spouse or partners, and sickness. So with early recognition and diagnosis, then we talk about early intervention, both pharmacological as well as psychological intervention. With pharmacological intervention, it is found that patients on lithium were less likely to die by suicide and less likely to undertake deliberate self-harm. And overall, there are also fewer deaths for patients that are on lithium. For psychological intervention, most of which has already been elaborated upon by Patricia earlier on, psychoeducation to patients, their families, and caregivers is very important. This is to allow them to have a clear understanding of the illness and its progress and its progression, and to familiarize not only the patient but the caregivers and family members to the early warning signs and the unique relapse signatures that the patient may have. It is useful to come up with a plan of action which takes a collaborative effort between the patient, the family members, caregivers, and the health providers. And it would include and cover things like what to do during a crisis, who to contact, the support resources that are available within the family as well as in the community. There are also more specific psychotherapy methods, which Patricia has alluded to, such as cognitive behavior therapy, family therapy, and interpersonal social rhythm therapy. All this can help our patients cope with stressors better. And finally, when do we refer patients on to tertiary centers? It is a real challenge in determining how close a patient may be to attempting suicide. Well, as a general guide, patients who report of active plans and thoughts of suicide, and when the assessment indicates that there is little to prevent the patient from making such an attempt, this patient must be protected. And this may mean an urgent referral to a psychological services, close observation in the care of family and friends, and or even hospitalization for stabilization. These are my 3 take-home messages. I think we need to recognize that there is a high risk of suicide in patients with bipolar disorders, and adopt a routine assessment for risk of suicide in patients with bipolar disorders. And like what Yimeng has alluded to earlier, the risk of suicide can be reduced with timely recognition and appropriate intervention, and bipolar disorders can be managed. And with that, I thank you for your attention.